Welcome back to The Explainer. Today we're diving straight into a highly logical cheat sheet breakdown of a true life-threatening hematologic emergency. I know you're looking for a focused, direct understanding, so we're going to build a really clear step-by-step mental model of thrombotic thrombocytopenic purpura. Let's get right into it.
Here's our game plan for today. 1. Causes and pathophysiology. 2. Clinical signs and symptoms. 3. Investigation protocols. And 4. Management and treatment. All right, Part 1. Causes and pathophysiology, the molecular battlefield. Let's get our definition straight right out of the gate. TTP is a severe thrombotic microangiopathy. To break that down, thrombotic means clots, and microangiopathy means disease of the tiny blood vessels. We're talking about widespread, microscopic clots clogging up your terminal arterioles and capillaries. And as these clots form, they're actively chewing up your platelets. Then, as a devastating physical consequence, they completely destroy the red blood cells trying to pass through.
Now look at how clearly this divides into two main culprits. It's all about an enzyme called ADAMTS13. You're either born without it or your body suddenly attacks it. On one side, we have congenital TTP, also known as Upshaw-Schulman syndrome. That's a genetic mutation where the patient is simply born missing that crucial ADAMTS13 enzyme. It can show up in the first weeks of life or sometimes hide until adulthood, like during pregnancy. On the flip side, there's immune-mediated TTP, or ITTP. This one's an acquired disorder. Out of nowhere, the patient's own immune system starts pumping out IgG or IgM autoantibodies that completely neutralize or clear out whatever ADAMTS13 they have.
So how does this actually trigger a molecular disaster? Well, think of ADAMTS13 as a pair of molecular scissors. Its one and only job is to snip up these massive, sticky nets made of a protein called von Willebrand factor, or VWF. Step 1, you lose the scissors. Step 2, without them, these ultra-large VWF multimers just pile up in the bloodstream. Step 3, passing platelets get snagged in these giant, uncut nets, clumping together to form microthrombi. And finally, Step 4. As your red blood cells try to squeeze past these microscopic traffic jams, they are literally sheared and broken apart. That right there is the core engine of TTP.
Moving on to Part 2, Clinical Signs and Symptoms, the Bedside Picture.
Since we just mapped out the pathophysiology, the classic clinical pentad is going to make perfect sense. First up, microangiopathic hemolytic anemia, or MHA. That's the physical shearing of those red blood cells against the clots we just talked about. Second, severe thrombocytopenia. Your platelets aren't just magically disappearing, they're being aggressively consumed to build those exact same clots. Third, neurologic symptoms. Think confusion, stupor, or even seizures. Why? Because those microclots are lodging right up in the brain's tiny vessels. Fourth is renal failure from those same blockages in the kidneys, though to be fair, this is usually less prominent here than in HUS. And finally, fever. It's just your body's massive systemic inflammatory response to all this cell destruction and tissue ischemia.
But wait, here is a massive clinical trap. Please, whatever you do, do not wait around for all 5 of these symptoms to show up. Less than 5% of patients with immune-mediated TTP actually present with a full clinical pentad. Seriously, if you wait for the whole textbook picture, you're going to be waiting way too long and your patient is going to be in grave danger. Let's jump to Part 3, Investigation Protocols, the diagnostic workup.
When you suspect TTP, your workup has to be rapid and systematic. Step 1, pull a CBC. You're looking for that severe anemia and marked thrombocytopenia. Step 2 is absolutely critical. Get a peripheral blood smear and hunt for schistocytes. Those are the shattered, fragmented red blood cells we discussed earlier. Step 3, run a hemolysis panel. Because those red cells are bursting open, you'll see lactate dehydrogenase, or LDH, absolutely spike, while haptoglobin plummets because it's soaking up all that free hemoglobin. And Step 4, check your coags. In TTP, your PT and PTT are usually totally normal. That is a massive differentiator, guys, because it separates TTP from DIC, where the coagulation panel would be completely out of whack.
To definitively lock in your diagnosis, you have to order an ADAMTS13 activity assay. You're looking for an activity level that is severely depressed. We're talking below 5 to 10%. Once you get that wildly low number, you immediately follow up with an autoantibody screen. If the autoantibody is there, boom, you've got immune-mediated TTP. If it's missing, you're likely looking at congenital TTP.
All right, our final section, Management and Treatment, the Pharmacy Protocol. This is your ultimate treatment cheat sheet, and it ties right back to our molecular battlefield.
For immune-mediated TTP, your first-line strike is aggressive plasma exchange combined with prednisone. Plasma exchange is basically a 2-for-1 deal. It filters out those nasty autoantibodies, and it pumps in fresh plasma loaded with functional ADAM-TS13 enzyme. Now contrast that with congenital TTP. Since there are no autoantibodies to fight off, you usually just need simple plasma infusions to top up the missing enzyme, though you can definitely use exchange if you need to push large volumes safely.
And I definitely have to highlight caplisumab here. It is an absolute game changer for immune-mediated TTP as an adjunct therapy. It's a humanized monoclonal antibody fragment, and its mechanism is just brilliant. It binds right to the A1 domain of von Willebrand factor. By doing that, it acts like a physical shield, literally blocking those sticky VWF nets from grabbing onto passing platelets. When you add this to plasma exchange and steroids, it drastically speeds up platelet recovery and drops the overall risk of death and secondary clots.
So why the intense urgency with all these protocols? Well, keep this number burned into your memory. Untreated immune-mediated TTP has a staggering mortality rate of over 90%. 90%. Let that sink in. And even with our absolute best modern therapies, 20% of patients still don't make it past the first month due to microvascular clotting complications. Make no mistake, this disease does not wait for anyone.
Rapid recognition is literally the difference between life and death here. It all comes down to connecting that invisible molecular lack of ADAM-TS13 to the harsh bedside reality of sheared cells and missing platelets. So the real question I want to leave you with today is this. The next time a patient rolls in with unexplained anemia, critically low platelets, and schistocytes on a smear, will you be ready to deploy this cheat sheet and save their life? Thanks for tuning into this explainer. Keep this framework fresh in your mind, and we'll see you next time.